Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome back to the fifth day of the ninth Jakarta International Chest and Critical Care Internal Medicine (JICCIM 2021) live webinar. My name is Rizky Korata Aini, and I will be your host for today's event. Today, we will be having 3 lecture sessions. We are sure that today's session will enrich our understanding and our knowledge even more. Before getting into the sessions, we would like to remind you that first, all participants of the JICCIM 2021 are expected to attend the webinar attentively. Certificates will only be given to participants who attend at least 70% of the whole webinar. Second, participants may use the Q&A feature in the Zoom webinar if they have any question for the speaker. You can ask the questions during the lecture, and there is no need to wait until the speaker is done speaking. Lastly, every week on Sunday, there will be a door prize announcement. 3 prizes every week will be given to the most active and attentive participants. Ladies and gentlemen, we are now entering our first session, the 11th sessions of JICCIM 2021, in which we will be discuss about interventional pulmonology. Speakers in this session will be Dr. Melvin Tai Jiccim from Singapore and Dr. Gurmeet Singh, spesialis penyakit dalam konsultan pulmonology. This discussion will be moderated by Dr. Daniel Tenda, spesialis penyakit dalam, Finasim DIC, PhD. Dr. Eric is a head of Artificial Intelligence and Digital Technology in Medicine Research Group, Indonesian Medical Research Institute. He is also a medical staff, Division of Respirology and Critical Care, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipta Mangunkusumo Hospital. Without further ado, Dr. Eric, the floor is yours.
Thank you very much. Bismillahirrahmanirrahim. Good morning to everyone. Once again, thank you very much for joining us. So, on behalf of the Jakarta International Chest and Critical Care 2021, I would like to say thank you again for all the participants, all speakers, and moderators for actually attending our symposium. I think this is already um, the third leg of GICCM this year. So, as mentioned, I'll be the chairperson for today's session, which is session number 11, and we're going to discuss about interventional pulmonology. Again, my name is Eric Daniel Tanda. I'm one of the medical staff in, at Department of Internal Medicine. I'm an internal medicine specialist and interventional pulmonologist. Together with us, we have 2 speakers. The first one, I'm very delightful to introduce Dr. Melvin Tai Jiccim. Hello, Melvin, are you there?
Yeah, I'm here. Hello.
Hi, nice to meet you again.
Yeah, nice to
Dr.
meet you.
Melvin is very well known and respected doctor who is also very, very stylish this morning in Singapore. So Melvin was based in Singapore. He's also do a lot of interventional pulmonary procedures. Dr. Melvin latest position, he is a senior consultant in pulmonology medicine in Department of Respiratory and Critical Care, Singapore General Hospitals. He is also a consultant and acting director for interventional pulmonology as SGH, and also an adjunct assistant professor. I think you're already a professor yet, mate, at Duke NUS Medical School. So again, thank you very much, Dr. Melvin. So for the first topic for this 11th session, Dr. Melvin will present a topic with the title of rigid bronchoscopy and airway stenting in central airway obstruction. So Melvin, without any further ado, please start. Thank you.
Thank you. Can someone please give me the sharing rights?
Oh, yes. Can someone allow Dr. Melvin to share his screen, please? Got it?
Okay.
Excellent.
Okay, good morning, everyone. Thank you, Mr. Chairman, for the introduction. Firstly, I'd like to thank the organizing committee for this invitation to be here today. So I'm Melvin from Singapore General Hospital, and I'm currently the Director of Interventional Pulmonology. So today, I'm just going to spend the next 20 minutes or so to give you a broad overview of rigid bronchoscopy and airway stenting in central airway obstruction. So we're going to begin with the history of rigid bronchoscopy. So it's just going to be a quick one. So it all started in the late 19th century. So with Gustav Killian, who is a German ENT physician. In one of those nights, he used his laryngoscope to examine the airways of a patient, as well as removed a aspirated pork bone. And this was followed by the development of the rigid bronchoscope in 1897. And then across the Atlantic, Chevalier Jackson, who's a Philadelphia-based otolaryngologist, he was making a name for himself for extracting aspirated foreign bodies from the airways of children and adults. And as you can see in this picture, on the top left-hand side, he is like teaching medical students. And of course, if you ever have a chance to go to Philadelphia, you should make a trip to the Mater Museum. And the Mater Museum, it houses more than 2,000 collectible, okay, I won't say collectibles, but 2,000 items that Dr. Jackson removed from the airways of his patients during his 75-year-long career. And of course, subsequently in the late 1960s, because of the introduction of the flexible bronchoscope invented by Dr. Shigeto Ikeda, it sort of led to the decline of rigid bronchoscopy. And so that picture over there, it's in the Mater Museum on the top right-hand corner, it's a kit. I think you can see that it's a rusted safety pin, which Dr. Jackson removed. All right, and then it was only in the 1990s that Dr. Jean-Francois Dumont, considered by the community to be the father of interventional pulmonology, who rejuvenated the interest back in the rigid bronchoscopy through his work in endobronchial therapies, especially laser and stenting. All right, and so that was a brief history of rigid bronchoscopy, and I thought it would be useful for me to divide my lecture presentation today into 3 parts. So we're going to start with first clinical applications of rigid bronchoscopy, and then followed by pre-procedural considerations, and finally we'll end up with some procedural tips. Okay, let's begin. So before we answer the question of clinical applications, we have to appraise whether the pros and cons of rigid bronchoscopy, and is it a necessary tool since that now we have the flexible bronch. So as we all know, the flexible bronchoscopy is widely available. It can be done. The procedure can be performed under conscious sedation, and the majority of us are trained in it. And because of the flexibility, it allows easy access to more distal airways, as well as the upper lobe bronchi. And in comparison, the rigid bronch has got its own set of advantages. So number one, it's done under general anesthesia. So we can ensure that the patient has adequate ventilation. It is also able to dilate strictures as well as cord tumors because it's just structurally more rigid. And at the same time, it's still able to isolate the left and main bronchi. And because the channel is a lot bigger, so it's got better suction capabilities, and the instruments are also larger. And finally, the insertion of a silicone stand would require a rigid bronchoscope. So now that we've talked about the pros and the pros of having a rigid bronchoscope, we have to also understand what the contraindications to rigid bronchoscopy are. So generally, they include contraindications to general anesthesia. So if the patient is has got any very unstable heart disease, would be a risk for general anesthesia, then he or she would not be a good candidate for rigid bronchoscopy. And very importantly, patients with cervical spine problems, whether it is unstable or fused, they would also not be suitable for rigid. Then other contraindications would include maxillofacial injury and other contraindications that apply to flexible bronchoscope. So this is just a slide showing the different systems of the rigid bronchoscope that are commercially available. So on the top left-hand, on the right-hand side, we have the most commonly used Eva Dumont set, name of the Dr. Dumont himself. And on the left-hand side, at the bottom, we have the Carl Stock's system. And finally, we have the recently we have the Dutal Novatech system, which is a bit newer, but it's just sort of like a improved version of the Eva Dumont set. However, in SGH, because we're such an old hospital, we're still using an Eva Dumont set that it's, I heard, like 20 years old. So moving on, let's go through the indications of rigid bronchoscopy. So today, the bulk of my lecture will concentrate on central airway obstruction. So, but besides central airway obstruction, there are other indications of rigid bronchoscopy, commonly such as the extraction of foreign body, like Dr. Chevalier Jackson in the United States, about 100 years ago. And at the same time, rigid bronchoscope can be used, is important a tool in the management of massive hemoptysis and to obtain large tissue biopsies. So as you can see in the picture below, if you can see, just direct attention to the figure at the bottom right-hand corner. So if you can see the X-ray, there is a hyperdense or radio-opaque opacity, just retrocardiac location. Okay, anyway, that was a patient that who is a GP practicing in the UK, and I think it was about 3 years ago. She was in Singapore for Christmas with her family, and because she wears a headscarf, and she during preparation before she goes out for dinner, she had like 3 scarf pins at the same time in her mouth. And I think because she was so excited, I think she aspirated one of it. And she came in the middle of the night to me on Christmas night, Christmas Day, the night of the Christmas Day. And I remember I just finished watching a movie by myself. And I was feeling very sorry for myself. And I had to come in the middle of the night, but it was fine. And the problem was that, when I did the rigid bronch and then put in the flexible bronchoscope to examine the airways, I couldn't find the needle or the pin, sorry. And so in the end, I used, I didn't have like a magnetic probe. I end up using a cardiac magnet, right? And then to sort of like magnetize the probe, or rather the forceps, and I somehow managed to fish it up. Okay, so moving on, let's talk about central airway obstruction. So the central airway refers to the trachea, as well as the bilateral main stem bronchi, as well as the bronchus intermedius. So the causes of CAO can be classified into either malignant or benign. So the most common malignant cause of central airway obstruction would be primary lung cancer. It's a no-brainer. And then, of course, secondary cancer, which means a non-lung origin. And this can happen either by airway metastasis. So, for example, a common tumors that metastasize to the airways would include thyroid cancer, breast, colorectal, as well as a renal cell carcinoma and melanoma. On the other hand, the non-lung origin cancer can also directly invade the airway. So most commonly, we have C. esophagus. And less frequently we see, but we still see from time to time, there is the primary tracheal cancer. And in terms of benign causes, the most common is, especially in this part of the world, is still pulmonary tuberculosis with endobronchial involvement. Traumatic, it's I don't know. In when I was like doing my training in Seoul, they had a lot more traumatic, like for example, post-intubation and tracheostomy, tracheostenosis. But in Singapore, it doesn't seem to be so common. And other causes would include post-lung transplant, rejection, burns, inhalation, and injury. And of course, finally, inflammatory causes such as relapsing polychondritis and miscellaneous causes, for example, tracheobronchomalacia. So before counseling the patient for rigid bronchoscopy, we will have to know what the complications are. So in rigid bronchoscopy under trained hands, it's really safe. In fact, sometimes I think it's safer than flexible bronch because the general anesthesia, the ventilation is secured. So I would usually tell the patient that the most common side effect that he or she would experience would just be a sore throat, which would go away in a couple of days. In fact, 1 to 2 days, and it's fine. Of course, we have to counsel the patient about dental, laryngeal, as well as airway injury, including airway perforation. But that has hardly ever happened in my practice, especially, in terms of airway perforation. And upper airway edema, temporary or prolonged mechanical ventilation, bleeding, and the need for a repeat procedure. Okay, sorry, there was some interference. Okay. Okay, so to finish up the first section, I would just like to quote Dr. Artu Mehta from Cleveland Clinic. So a good bronchoscopist is the one who knows when not to do the procedure. So there's a lot of wisdom in this statement. Okay, and that brought us to the end of section 1. So we'll move on to section 2, and section 2 is about pre-procedural considerations. So before doing therapeutic bronchoscopy, one should ask ourselves a few questions. Okay, so this is something like a existentialist kind of questioning, but it's to do or not to do. Okay, so in order to address that question, you need to ask yourself more questions. So I think you just have to limit yourself to maybe 3 questions. So the number 1, very importantly, is the breathlessness, right, that the patient is experiencing, largely caused by the CAO. So especially in malignant, CAO, a lot of patients may have, the concomitant pleural effusion, or like lymphangitis, carcinomatosis, and there are so many reasons, or like, PE. So we have to really assess properly in a patient clinically, and that breathlessness that the patient is experiencing is largely caused by the CAO. If not, if we are to subject the patient to procedure, and even despite having a successful procedure, the patient is not going to have much relief of symptoms, which is, pointless. All right. So as we all know, significant central airway obstruction, it's defined, right, only if there is a luminal narrowing by more than 50%. And it's just commonly accepted knowledge that for the for tracheal stenosis, the patient usually would not be symptomatic until the tracheal diameter becomes about 8 or less. And of course, by the time it's 5 millimeters or less, the patient would be likely breathless, even at rest. The second question that we should be asking is that, is the lung distal to the obstruction viable? So because that would really determine whether we should be intervening or not. Because if the lungs distal to obstruction are already infiltrated by tumor, then there is no point of us opening up the bronchus, right? And number 3, which is super important, we always have to consider, especially in young patients and as well as short segment stenosis, that surgery remains an option, okay? We have to ask ourselves all these questions because, even though, we are interventional pulmonologists, we like doing procedures, but, sometimes doing procedures on patients could worsen things for them. So for example, you could extend the length or size of the lesion or defect. Number 2, you could also convert a simple lesion to a complex one. And sometimes you could also cause the patient not just to have a stenosis, but because of your intervention, you can cause concomitant malacia, which will also complicate matters. So in our hospital, we have established a workflow for patients with a acute symptomatic CAO. So this is sort of like a pathway that I have worked up with the ER physicians, because it's very important, because every time they come in with stridor, they need to know who is the most appropriate discipline to make referrals to from the ED, from the ER. So this is just one of our workflows available in SGH. So for procedural evaluation, it's very much like intubation, because rigid bronchoscopic intubation is like almost the most important part, all right? So we have to assess whether the patient has got a difficult airway. And how do you assess that? It's, can get this off any anesthetic textbook. So things like upper incisors length, the upper and lower teeth relationship in terms of jaw, when the jaws are closed, the inter-incisor distance, pteromental distance, neck range of motion, and all. So at the same time, we would most probably would have some radiologic or endoscopic evaluation before rigid bronchoscopy. So of course, on the imaging, usually would be a CT thorax. Sometimes in certain centers, they may want to have a 3D reconstruction, but I don't really think it is always necessary. So, radiologic evaluation would include determining the severity, the type, and length of the obstruction. And very importantly, the vascular relationship of the obstruction with the surrounding major structures in the thorax, as well as the pulmonary status. Endoscopic evaluation, it's also quite pretty straightforward. Number 1, we need to know where is the stenosis, and we need to know how severe it is. The type, I'll come to that in my next slide, as well as the length, because we were saying that if it's a short segment, young patient, and it's got no surgical contraindications, surgery would be the definitive therapy. At the same time, we also like to pay attention to the structural distortion, the distal airways patency, which I've already mentioned earlier, as well as the bleeding risk. So for example, if during flexible bronchoscopy, easy contact bleeding, then you should be prepared, during rigid bronchoscopy that the patient may bleed. You may want to prepare all your therapeutic options such as ice cold saline, diluted adrenaline, as well as some heat ablative therapies. So as I've mentioned earlier in the previous slide, as you can see in these three figures, so I'd like to direct your attention to the top left-hand corner. So you can see that you need to know where the location is, right? And the degree, so you can do it upper third, middle third, lower third of the trachea, left or right main bronchus, or bronchus intermedius. And at the same time, you should also try to sort of estimate the severity of the degree of the stenosis. So as you can see, the picture, the figure at the left bottom corner, you can see that this is just a rough gauge of the degree of stenosis with the estimated percentage. And the type of stenosis is very important. We need to determine during bronchoscopy, whether flexible or during the rigid itself, if the stenosis is intrinsic, which means it's predominantly endobronchial, or it's extrinsic, which means it's just a compression from the outside, or it's a mixed lesion. So because that will affect our therapeutic strategy. So I think the next question to ask, right? So we have the first question is to do or not to do. So we need to ask ourselves whether the patient will benefit, and then next once we see we have already gone in to do something, we need to determine the location, the severity, the length, right, and the type of stenosis. And then the second important question that we should ask ourselves is airway stenting needed, to stent or not to stent? And to address that question, we need to know what are the common indications for airway stenting. So very commonly, if it's a simple, for example, extrinsic compression from a tumor or lymph node, we can just throw in the stent. Or if you have a primarily intrinsic stenosis, so endobronchial tumor, after you have performed all your therapeutic ablation and debulking and removal, you would also may want to consider a stent to stabilize the airway patency. And airway stenting can also be used to treat benign strictures, but only the non-metallic ones, right? And the airway stenting can also be used to stabilize collapsing airways, such as tracheobronchomalacia. And finally, it can also be used to sort of like seal up a aerodigestive tract fistula. And you can see from the pictures below, from left to right, from the left, you have the silicone stents, and then followed by the metallic stents. And these are just versions of, these are all different kinds of Y stents, from silicone hybrid to metallic. So let's go to, since part of the topic, it's about airway stenting. So what is the ideal airway stent, right? So what are the characteristics that in our mind that an airway stent should have? I'll just put it very simply into 6 points. So number one, it must be competitively priced. Shouldn't be too expensive. So in Singapore, our metallic stents and the silicone stents are about the same price, about $2,000. The Y stent is a bit more expensive, maybe $2,500. All right. Second, it must be easy to deploy and easy to remove. All right. And the complication rates of deploying the stent must be acceptable, which means must be low. And number 5, it must be an all-rounder in terms of indications, which means that the ideal stand should be able to be used either in benign or malignant diseases. Okay, and number 6 is adaptable. It must be adaptable. So in the figure on the top left-hand side, you can see this is how a stand is generally deployed. You can see in picture A, there is a fibrotic stricture, like a cicatricial kind of stricture. And this kind of strictures are very simple. You just need to make some radial cuts with the laser, after which you just dilate the stricture with the rigid barrel. And then you can insert the silicone stand, and then you just sort of like minor adjustments, and voila, it's done. The removal of the silicone stand is also fairly straightforward. You just need to just grab it with the rigid forceps, and usually you like to twirl it around so to contract its diameter, and usually try to bring it into the part of it into the rigid barrel. And then you just have to remove the stand with the rigid bronchoscope on block. And the picture that you can see, that is a peculiar picture with a very dark stand. That is from one of my patients. Actually, she had a stand put in by another interventional pulmonologist, like, I don't know, like 10 years ago, and somehow it was like forgotten. And then she came in with, symptoms of, sounds like she had recurrent, very non-severe episodes of tracheitis kind of thing. And, when I took out the stand, it was like already this color. It's, it's supposed to be translucent, but it's looking very brown in this and dirty in this picture. Okay, so to summarize what we have discussed earlier, so this is just a comparison table between the silicone and the metallic airway stand. So in terms of pricing in Singapore, it's about the same. In terms of ease of deployment, the metallic stand is of course easier because you literally just need to pull a string, and you do not need a rigid bronchoscope for it. In terms of ease of removal, the silicone stand is of course much easier to remove, although you will need a rigid bronchoscope to do that. But for the metallic stand, because of the epithelialization, it can be quite a horror to remove a metallic stand that has been placed in situ, especially for a long time. All right, and then in terms of complication rates, I think it's about the same, just that the migration rates of the metallic stand appears to be a bit less, especially a bit less because the self-expanding mechanism does help with it. So the sizing does not need to be as, how do I put it, as discerning as the silicone stand. In terms of all-rounder indications, of course, silicone stand would trump the metallic stand because silicone stand can be used for both malignant and benign etiologies, whereas the metallic stand has got a FDA black box warning that it can only be used, it should not be used in benign ailments. And adaptability, I think both are about the same. So anyway, so just to look at the figures, you can see, let me see. So on the left-hand side, the top left-hand corner, you can see that obviously the stand has sort of migrated from the left main bronchus into the distal trachea. And on endoscopic image, you can see that there's a formation of granulation tissue, because of the movement in and out. And this is confirmed when you finally remove the stand with the granulation tissue stuck inside the stand lumen. And the same thing can happen for the metallic stand, and as you can see in the picture below. And so what do you mean by adaptability? So adaptability would comprise, number one, the resistance to compression. Number two, its ability to conform to distorted airways, ability to seal airway fistulas, treat airway dehiscence, and customizability. In the picture on the left-hand side, you can just see that on the Dumont stand and the Ultraflex stand, of course, the Dumont stand, because it's silicone, it has got a greater resistance to compression, whereas the Ultraflex, which is the metallic stand, covered stand, it resists compression, but still less than the Dumont stand. And the pictures that you can see, further pictures, in the middle third, the two pictures. So this is a disaster, because this was a patient of mine, but he had an Ivor Lewis operation. And I think there was an anastomotic breakdown, which was detected late by the surgeons. So by the time he had recurrent pneumonias, we went in for the bronchoscope and found that there was a fistula opening into the right main bronchus. And the gastroenterologist had a very, how do I say, had tried to have a heroic attempt to close up the defect from the esophagus into the airway using clips, but obviously it didn't succeed. And I ended up having to remove all these clips that were just sort of like migrating into the right main bronchus. But anyway, and then finally the pictures below, as you can see that you can customize the silicone stand by cutting holes, right? For example, you want to deploy a stand in the right hand side, and because the right upper lobe takeoff is pretty short, sometimes you may want to just cut a hole. And you can either do this by in very low tech ways, like using scissors, or you have the dedicated instruments. Okay, and you can see on the bottom right hand corner, so that it's the stand. This stand is called a natural stand, but it has already it's no longer in production, but it was designed by my mentor, Professor Kim Ho Jung, and we wrote a paper together about angulated stands, whereby we sutured the stands together, to just sort of like fit better into post-TB bronchial stenosis, because they often have very sharp angulations in the bronchial alignment. Okay, and then anesthetic considerations. I won't spend too much time. Same thing, difficult airway. You need to discuss with your anesthetist regarding the anesthetic strategy and plan, whether you're going to use conventional or jet ventilation. And of course, you have to develop rapport with your anesthetist, because intraoperative desaturations can happen quite commonly, especially if the patients are very unwell. So in terms of complication rates of therapeutic bronchoscopy, this data is from the AQUIRE registry from the United States. Generally, the overall complication rate is only about 4%. Mortality from complications is less than 1% at 0.5. Risk factors for complications. Okay, this is not talking about rigid bronchoscopy. Moderate sedation, it may not be so safe, like I've said earlier. And of course, in patients who require any form of urgent or emergent procedure, and the ASA score of more than 3, and redo therapeutic bronchoscopies, they are at risk of higher risk of complications from the procedure. And moving on, the mortality rates for therapeutic bronchoscopy. So the 30-day mortality for first intervention is about, from the AQUIRE registry is about 15%. And most of the time, these patients are, having advanced cancer, and rigid bronch is often performed as a palliative procedures to relieve them of distressing symptoms of shortness of breath. All right, and then what are the risk factors for mortality? As quite similar to risk factors for complications, the ASA score, which is high, or any extrinsic or mixed obstruction, because like I said, for an extrinsic obstruction, which is predominantly just compression from the outside, is just very easy. You just need to throw in a stent. Whereas for intrinsic and mixed, you need to do some endobronchial therapy before you put in the stent. And of course, if the patient requires a wide stent, right, it means that the extent of disease, right, is larger, and therefore, logically and naturally, the patients would be at a higher risk of mortality. So I am going to finish this section 2, just bear with me. So for challenging cases for beginners, number 1, you have to be careful, be cautious of carinal lesions, bilateral disease, and of course, disease in a post-pneumonectomy patient, because the lung reserves have been halved. And finally, we are going to go to the final section, which is procedural tips. Very, very simple. Okay, so tip number 1, when you are maneuvering the rigid bronchoscope, always stay in the midline during intubation, right? Because it is very crucial for you to stay in the midline so you can identify all the pivotal structures for you to perform a successful and smooth and atraumatic intubation. So as you can see in the figure that I think my arrow is pointing at, you first see the first landmark is the uvula, followed by and then you slide the rigid barrel along very gently along the pharynx, and until you see the epiglottis, after which you would just slip the rigid the bevel underneath the epiglottis to expose the vocal cords. And when you are maneuvering the rigid barrel within the central airways, right, you have to make sure it's always in the center. And therefore, and sometimes it may be difficult because your visibility may be compromised by bleeding, tumor, but you must roughly have a feel. Okay, I won't say roughly. You must have a feel of that your scope, right, remains in the center of the airway, because if not, you will run a high risk of perforating the airway, causing airway lacerations and subQ emphysema and blah. So, and therefore, the barrel must always be in sight. Okay, the barrel must always be in sight. You must see the barrel, and you must know where you are. And ideally, you should be keeping the barrel within the center of the airway. And do not advance the scope within the airways if you cannot see clearly. All right. So, yeah, if there's no visibility, it's a no-go, unless sometimes very, very emergent situations whereby you have massive hemoptysis. Of course, I've done that before, but you just need to be experienced. You must have roughly a feel of where you are going. Okay, so this feel, I cannot overemphasize more, that you need to get a feel of maneuvering the scope within the airways. And this feel is the same feel that you need to have when coring out tumors using the bevel of the rigid bronchoscope. Anyway, this is just a video, just for fun. So this patient, this is in real time. I have not increased the speed or reduced it. So this is a Malaysian gentleman who, 50 years old, presented with chronic cough. X-ray had some right lower lobe infiltrates. CT thorax showed that there was some already developing bronchiectasis. Not sure whether there was a foreign body or not, because that place was just a bit messy. And then in the end, it turned out to be a chikunat. And this chikunat, it's almost like 3.5 centimeters. Until now, I don't even know how the patient managed to aspirate such a big chikungunya. And when I asked him, when was the last time you ate a chiku fruit, right? And then he said, maybe 2 years ago, because that was the last time he went back to Johor, where he lives, and he has got his house has got a backyard where they grow chiku fruits. They planted chiku trees, So he had that in him for like 2 years without knowing. And then the next one would be, this is a very complex case. Similarly, the speed is normal. So you can see the intubation process. And this is a 40-year-old gentleman who is very unfortunate. He had a Bohavs and then subsequently had a tracheal repair, which didn't quite work out. And then the tracheal defect was like, instead of like closing it up, it got bigger. And of course, this was done because the surgeon said, oh, the patient was too sick to go for surgery, so I had to put in a stent. And you can see that at that corner just now earlier. Okay, let me rewind it a bit. Okay, you can see that that is a fistula and it's very huge, and therefore you need to know how to maneuver the rigid bronchoscope right above that huge defect. Right, you almost didn't see it, but honestly, it was there. So let me just rewind it a bit for you. So you can see sometimes your visibility may not be ideal. So you can see, I sort of know where it was, but it was a huge defect. But yeah. So this is what I mean, that you need to have a feel. You need to know exactly where you are before you do anything, and just deploy the stent. And subsequently, he got better and went for surgery and, got out of the hospital. So like Dr. Chevalier Jackson said before, the bronchoscopists must have eyes on the tips of their fingers. So I guess this thing has to be, picked up with procedures and, experience, because it is not so easy. I mean, you can read how to do it, but you must feel it when you are doing it. So I think this is what he meant. And the other thing that I'd like to offer some advice is that during the procedure, you need to know about the vasculature of the trachea. So the interventional pulmonologist should have at least a decent idea of what is the arterial supply of the trachea, whether it's the cervical trachea, the thoracic trachea, and which part of the, whether it's from bronchial arteries, or it's from the inferior thyroid arteries. But regardless, the most important thing that you should pay attention is that most of the arterial supply that is feeding the trachea, it's located posteriorly. Okay, it's located posteriorly, and therefore, when you are maneuvering or doing interventions, either in the posterior wall or in the corners between at the junction of the cartilage and the muscular wall, you should be very careful. So I'd like to highlight an example. This is another patient that I saw. So you can see this huge tumor, and it's very dark colored, right? And arising from posterior wall. So this person has got a metastatic melanoma. So melanoma has metastasized to the airway, and he was symptomatic from it. So while waiting for some immunotherapy and all, I had to do some therapeutic maneuvers, and and when I was debulking the tumor, right, melanomas are known to bleed. Okay, but more importantly, it's I think I must have caused an arterial spurt. When I was at the junction of the cartilage and the posterior wall, but of course I recognized it, and with the rigid barrel, you can actually just apply direct manual pressure on the arterial spurt, so, and it stopped. But I'm just saying that you have to be very careful, and you need to recognize complications and know what to do when that arises. Yeah, so that is the melanoma. I didn't manage to get the video up of the spurt, but I think I should try the next time. Anyway, so I'll just finish my presentation with words of wisdom again from Dr. Atumeta. So interventional pulmonology is more than just interventions, all right? You have to be a good bronchoscopist to be an interventionist. So good old basic bronchoscopic skills, navigation, keeping in the middle, good airway, topical anesthesia, all these things are key. All right. If you don't even have the basic foundation, then you will not be a very good interventionist, right? Because interventions don't make you a better bronchoscopist, right? So it's you have to be a good bronchoscopist first in order to be a good interventional pulmonologist and not the other way around. And because it could be done, doesn't mean that it should be done. And there's so much wisdom in this because like we have already gone through earlier, the good interventional pulmonologist is the one who knows what not to do, what not to touch, right? And what to say, okay, I can do this, but is it going to help the patient? Or is it going to cause more problems? So, just because it can be done doesn't mean that it should be done. The problem with interventional pulmonology, I don't know, I just feel that sometimes because, it self-selects a particular profile of people. So, people who like doing hands-on, people who like the adrenaline rush, right? And people who like to say, oh, I can do this, I can do that. But the wisdom is, if you don't have to do anything, right? If it ain't broke, don't fix it, right? And because you need to always put the patient's safety and well-being, right, before your own ego, which means that, you should not be doing things to self-gratify. I mean, I've done difficult cases, but, I'm not going to put it online and tell people that I've done this and done that. It's okay, right? I mean, the most important thing is that your patients do well, and then, you have yourself, you sort of like get yourself a repute that you are a very safe, right, and wise interventional pulmonologist. And of course, reducing healthcare costs is a civic responsibility because you should only perform rigid bronchoscopy only if it's needed, right? But I mean, because it is, after all, a bit more expensive, you need an anesthetist, general anesthesia. So I think Dr. Atumeta's words of wisdom should stay with us. And with that, I thank you, and I'll hand over back to the Mr. Chairperson. Thank you.
Right. Thank you very much, Dr. Melvin, for your very nice lecture. I think we're a bit over time. So I would like to invite the second speaker for today, Dr. Gurmeet Singh, with the title of Looking Deeper into Peripheral Lung Lesion with EBUS TBNA and TBLB. So Dr. Gurmeet Singh his current position is the head of Division Respirology and Critical Illness, Department of Internal Medicine, Faculty of Medicine, University of Indonesia, and Cipto Mangunkusumo National General Hospital. He's now a PhD candidate at University of Indonesia. Without any further ado, Dr. Gurmeet Singh.
Yeah, thank you, Dr. Eric. Good morning to all our participants. Thank you, Dr. Melvin Thai, for your excellent presentation. So we were supposed to meet last year, I think. We were supposed to organize our rigid bronchoscope workshop. Yeah, we got all well prepared, but due to this COVID-19 pandemic, we have to reschedule, I think, our workshop. We have to do this virtual conference, and hopefully, probably next year, everything goes well. Yeah, we will continue our collaboration with you in doing this rigid bronchoscope workshop together with Dr. Naveen Kishore from India. So so I'll be presenting my talk about. Can you share the screen? So it's looking deeper into peripheral lung lesion with EBUS TBNA and EBUS TBLB. endobronchial ultrasound, transbronchial needle aspiration, and transbronchial lung biopsy. I'm more keen in doing EBUS DBLB actually in lots of my patients, but I think it's not that well popular compared to EBUS DBNA. So like Dr. Melvin Thai shared some words of wisdom from Dr. Professor Atul Mehta. So I follow this bronchoscopy haiku. So before starting bronchoscopy procedures, we have to know, I know where I'm going because the scope and I are one. Together we explore knowingly. So we have to study all the cases. We have to perform some discussions. We also have our board meeting in Indonesia, in Cipto Hospital. We have our interventional pulmonology meeting. We have our chest meeting. So we decide what is the best option for this patient. So it's not that while performing bronchoscopy we're going to search all this. We don't know where we are going, what we are going to do inside, unless it's an emergency case. So that's another situation. Yeah, I think I'm going to use that one. Okay, so interventional pulmonology is relatively new in pulmonary medicine, probably just quite advanced. Yeah? In Indonesia also, I think in the last 10-15 years, it's advancing, especially in Cipto Hospital, because we've got lots of respiratory disorders, including now we have got the COVID-19 pandemic. We also have been doing some interventional pulmonology in our COVID-19 patients. So it's an increased need for procedures. Not everyone can perform this interventional pulmonology. One has to be trained, taking this like a course, probably a fellowship, 1-year fellowship, or probably a 6 months fellowship. And usually it's been performed by respirology consultants, some pulmonologists, and also some cardiothoracic surgeon. Excuse me. This is a nice paper. I think all the participants who are keen in interventional pulmonology can browse through internet. They discuss, I think, thoroughly about interventional pulmonology, what can it offer for your patients. There are lots of discussions, including some indications, risk, benefits of the various interventional modalities that the pulmonology can decide what to do in the patient, because patient safety is the main factor while performing any kind of procedures, whether it's interventional pulmonology, it's surgical intervention. So it will be much better to decide to have a discussion with the patient and also with the family members. To name few, we've got bronchoscopy, transthoracic needle aspiration, transthoracic broncho biopsy, endobronchial ultrasound, thoracoscopy, rigid bronchoscopy like the presentation by Dr. Melvin Thai, and some pleural procedures, indwelling pleural catheter, cryotherapy, argon plasma coagulation, and also some more other procedures, airway stenting, BLVR, bronchoscopic lung volume reduction, and some vapor procedure, bronchial thermoplasty. But these are some of the interventional pulmonology that we have been doing in Indonesia, especially in Cipto Hospital. So we have been starting our more intense interventional pulmonology in Cipto Hospital since 2015. So these are some data that I collected in the last 5 years. So we have been doing a lot of TTNA, around 200 cases, and bronchoscopy is around 600 cases. Medical thoracoscopy, because it's in selective cases and undiagnosed pleural effusion, so it's only about around 20 procedures. And also, even though we are not that much in doing this airway stenting, but we have been we got now our rigid scope, so probably in the near future we can perform a lot more of this airway stenting. And also we have been doing this electrocautery and snare procedures. I've been doing this in complicated pleural effusions. So through thoracoscopy I've been doing this electrocautery and snare, and it's giving a better post-procedure option for the patient. These are the team in interventional pulmonology. Of course, respirology and critical illness consultant are pulmonologists. We don't have any respiratory therapists in our team, but in some paper they suggest that you have to have a respiratory therapist. Of course, we have our anesthesiologist colleagues assisting us in performing this interventional pulmonology procedures. Our nurses, well-trained nurses, not just a normal nurse, it has to be a nurse that is well-trained in doing this interventional pulmonology. And in some cases we also need some assistance through our pathologist colleagues while performing like some rapid on-site specimen examination through EBUS DBNA or through normal bronchoscopy. I would like to share a video, about a case that we did. So before performing like endobronchial ultrasound, endobronchial ultrasound TBNA or endobronchial ultrasound TBLB, we have to perform normal flex bronchoscopy. We have to evaluate inside the airway whether it will be enough to do this normal bronchoscopy, or should we continue to EBUS TBNA or EBUS TBLB, even though we have discussed the case before we do the procedure. But sometimes inside we find some small nodular lesions that we can just do some normal biopsy. So we discuss the pre-procedures. This is the team. So we do our normal bronchoscopy in the patient before performing the EBUS TBNA or EBUS TBLB, just to evaluate, just to collect some specimens, probably for some microbiology examination, because we have got lots of TB cases in Indonesia, so it's a routine procedure to collect specimens for tuberculosis. If there's some nodule inside the airway, we can do some biopsy before we perform some other procedures. So endobronchial ultrasound, we've got two types. We've got the radial probe that is for peripheral lesions or some consolidations. Even though it's central lesions, we can do the diagnosis through radial probe endobronchial ultrasound. We've got the convex probe. Majority of the cases, patient presenting with mediastinal lymphadenopathy, we need to evaluate whether it's an infectious causes or it's a malignant causes or it's a benign causes. So right now we can perform endobronchial ultrasound TBNA. So it's a technique which uses ultrasound. So you got a normal bronchoscope, and on the tip of the bronchoscope there's ultrasound probe, a mini ultrasound probe. That's where you insert it. And for radial probe, so the radial probe is quite a small probe. I think we have to take care of while doing these procedures. We insert to the segmental portion where we can see through the ultrasound monitor over here. Usually the normal view will be like a sandstorm appearance, so it's quite all white matter that we can see over here, but in this picture it's like a irregular lesion, so probably some malignant causes or some infectious causes. And for the convex probe, we can insert a needle which comes out at the mid portion of this ultrasound. We identify the mediastinal lymphadenopathy, we measure the size, we see whether it's homogeneous or it's heterogeneous, the regular irregularity or any other components inside the lymphadenopathy. And then we also have to evaluate that it's not a vascular structure that will be puncturing, and after that we perform some jab and some passes. Indication and contraindication. For indication, we can use it as a staging for non-small cell lung cancer. So sometimes we got a mass and mediastinal lymphadenopathy, chose to evaluate whether is it a metastatic lesion or some infectious lesion. Yeah, we can perform an EBUS TBNA. Intrapulmonary nodule assessment. We got a nodule inside. Of course, we have to evaluate. I've got some cases, a patient with a nodule, intrapulmonary nodule. In malignant cases, before performing the procedure, they thought that it was a progressive disease. They were gonna change the chemotherapy regimens, but I suggest that after discussion with our team member, we should evaluate this nodule, and performing this EBUS radial guided with fluoroscopy, the diagnosis came out to be tuberculosis. So we treat that patient for with ATT for 1 year, and she's got a good prognosis, and she is still comes to control in my OPD clinic. Also, we can use for guiding for endobronchial therapy. We have not been doing this endobronchial therapy yet in Indonesia. We can use this modality to evaluate some endobronchial lesion evaluation, probably some malignant or infectious causes. Before performing these two types of procedures, some contraindication we have to keep in mind. Patient safety is the main concern. So if the patient have got life-threatening arrhythmia, poorly controlled heart failure, some cardiac problems, it will be much advisable to consult, have a discussion with our cardiology colleague whether to go on with these procedures or whether to withhold, treat the underlying heart or the cardiac problems, and probably after a month, 2 months, we can continue with the procedures. Some hemostatic disorders also have to be kept in mind, thrombocytopenia and high blood urea nitrogen or serum creatinine, because this might be some bleeding problems or bleeding complication post procedures. One review article, this is from abroad, endobronchial ultrasound TBNA. So it's not it's much more than mediastinal staging. So they did separate from 5 groups: lung cancer staging, pathological diagnosis in advanced stage lung cancer, and lymphadenopathy in previous malignancy, and pulmonary lesion and unknown origin lymphadenopathy. And from these 5 groups, they found that they got a good sensitivity, negative predictive value, and diagnostic accuracy in all the 5 groups. So EBUS TBNA, it's able to dictate not only for conservative therapy, but also providing pathological diagnosis, mediastinal staging. And we know that right now in treating malignancy, especially lung malignancy, we need to perform lots of molecular analysis. and through EBUS DBNA we can get adequate specimen to continue with the molecular analysis. So EBUS DBNA is one of the best approach for invasive mediastinal investigation, confirming its strategic role and high accuracy in thoracic oncology. In Indonesia, we have also been, the most cases that we have been performing EBUS DBNA is in lower paratracheal. It's for R or the left side, left paratracheal. I think it's the same has been reported in this paper. So we have also been doing some EBUS DBNA in the interlobar. It's 11R and the left. And from these results also we can see from this paper that it's not only malignancy, it's not only metastatic lesion that we're getting through these procedures. They have also been reporting like tuberculosis. So I've got I think 3 or 4 cases in which they thought that this might be metastatic lesion, but while performing the EBUS DBLB, because I'm more keen in doing EBUS DBLB, so we found out that it's tuberculosis. And also in some cases we have got some hematoma cases, and also I think some NTM cases. So it's very helpful when you have mediastinal lymphadenopathy. We have to evaluate much further and not just take it for any metastatic lesion. And for EBUS DBLB, it's typically done some peripheral lung masses or solitary pulmonary nodules. Even though they have a high sensitivity and specificity for this procedure, but it will be much better if we can do it we perform this procedure in conjunction with fluoroscopy or navigational bronchoscopy. We don't have this navigational bronchoscopy yet in Cipto Hospital. We have got a tryout in 5 cases doing this combination with EBUS radial and navigational bronchoscopy, but I think the best outcome is while doing EBUS DBLB. The highest sensitivity is much better in our institution is combining with fluoroscopy. So another paper about radial probe EBUS for the diagnosis of peripheral pulmonary lesions. So the overall sensitivity was it's much higher for lesions that were visible through the radial probe EBUS compared to the non-visible lesion. And again, from this paper they find out that it's not only malignancy lesion, they also find out some tuberculosis or fungal infection. Although in Indonesia, where we perform this procedure, we haven't found any fungal, I think we found one cases, a leukemic patient with consolidation in the, I think in the right upper lobe. So we'll perform EBUS radial probe in conjunction with fluoroscopy, and it came out to be aspergillosis. I like to share some cases that we have been doing in Indonesia. So it's the first case is a 57-year-old male presented with hemoptysis. The thoracic CT scan, it showed consolidation in the left upper lung without any enlargement of mediastinal lymph node. Brain CT showed a space occupying lesion. So through discussion with our tumor board, our interventional pulmonology meeting, we decided to go with I think it was a EBUS radial procedure. So this was the procedure being done. So we found some mucosal irregularity and we performed the NBI, navigational band imaging. Even though we can just perform a biopsy in this regular biopsy in these cases, but sometimes our experience showed that while doing biopsy we usually get some necrotic tissue only specimen. So we decided to evaluate much further intersegmental. This is the EBUS radial probe being inserted, and this is the ultrasound view. So we have to identify the lesion. Okay, so this is a much better view through the ultrasound. And over here we see that we did not find that the normal sandstorm appearance. Instead we find this irregularity over here. So this is, we confirm that there is some lesion. Yeah? So probably this might be some malignant lesion over here. After confirming with the radial probe, then we insert the, I think, the cytology brushes. So this is quite confirmed. This is the lesion that we identified through our radial probe. Took out the radial probe. We did some measurement. We insert our forceps biopsy. We got the specimen, and the result was adeno-CA of the lung. This patient was further evaluated for brain radiotherapy and also some chemotherapy with our hemato-oncology colleague. This is the second case. So this is a 51-year-old female presented with chronic cough for about 3 months, and thoracic CT scan showed consolidation in the right upper lung with enlargement of mediastinal lymph node in station 7 and 11 hilar. So we had a discussion that we're going to perform EBUS TBNA and also EBUS TBLB. So we decided to evaluate whether this is a metastatic lesion or probably some infectious lesion in this patient. So I don't have the video of this EBUS TBLB, but we perform in the upper lobe, upper segment. I think this is the posterior segment. So this is the ultrasound imaging from the radial probe. This is another some irregularities. We identified the lesion over here. We insert the cytology brush. We did some cytology specimen, and also we inserted the forceps biopsy. We got some specimen, and this came out to be another case of adeno-CA. And this is the EBUS TBNA that we perform in the patient. So we identified the lymph node. So it's, I think, in 11L. So we identified the lymph node. We did some measurement, and we also evaluate this is regular and homogeneous. Okay, I'm just gonna skip some of the video over here. Just gonna show the passes that we did. So this is the, the point where the needle will be inserted. We're gonna see the needle being inserted over here. Yeah, I think, yeah, this is the needle being inserted. Yeah, this is the needle that we have been inserted, and now we have been doing the passes over here. We can see clearly that the needle is inside the lymph node. Okay, so this is important that we have been, this shows that yeah, the needle is inside the lymph node, and we should get adequate tissue specimen, and the result from this EBUS TBNA is similar to EBUS TBLB. It's positive for adeno-CA. So there's a statement on interventional pulmonology. Our participants can browse and can read that in doing this diagnostic and invasive therapeutic procedures, we require some additional training and expertise beyond that required in a standard pulmonary medicine training program. So in Indonesia, we've got this additional fellowship in interventional pulmonology, is still the basic interventional pulmonology. So hopefully in the near future we can have this fellowship program. And endobronchial ultrasound, TBNA, is much more than mediastinal staging, has been shown from the paper that I shared and through some personal experience that it's not that only metastatic or malignancy lesion, so it could also be some infectious lesions. And for peripheral pulmonary lesions, if one is quite good in doing this radial probe EBUS, yeah, it can offer a good modality for diagnosing in this peripherally pulmonary lesion. I think that's all from my side, Dr. Eric. Thank you. Back to you, Dr. Eric.
Thank you very much for your nice words. So I think it can sound from the communication again. How many minutes do we have for discussion? Is it 10 minutes? Oh, okay, all right. So I'm just going to ask a few questions. And I think, Dr. Melvin, thank you. You already answered in most of the questions in the chat box, the Q&A box. So I think, do you want to say anything in regards to the questions, Dr. Melvin, or any feedback on the questions?
I think the questions are really good, and I think most of the questions would have been answered by the lecture slides itself. Yeah. So, but I like the question about the emergency preparation. So I would like to highlight that the most important thing is we have to just really tell the patient and the family that because this is an emergency operation or procedure, the of course the pre-op assessment cannot be complete, right? We won't know sometimes even the heart status of the patient or whatever. We can only rely on very elementary tools like SpO2, recent ECGs and stuff like that. But I think the most important thing is communications with the patient, and so I think usually if that, and I usually, because a lot of all these emergency cases, say for foreign body aspirations, they are usually malignant cases. I would also usually engage the primary oncologist, right, to discuss all these things. So, of course, we won't have much time, but I think it's still good that, we have a primary oncologist to partake in the overall discussion. Yeah, so that is what I tend to do, but usually we move very fast. That's all. Yeah.
All right. Thank you very much, Dr. Melvin. I tried to scroll down if there are any more questions for you. I think there's one question. So this doctor asked about if obesity is part of the contraindication for rigid bronchoscopy. If no, what are the pitfalls of using rigid bronchoscopy in obesity?
So the obese patient poses several challenges. So number one, to the rigid bronchoscopist himself, in the sense that it will be a potentially difficult airway. So I think that is probably most of it. And then a lot of the other considerations would be from the anesthetic side. Yeah, because we all know that in obesity they have a low FRC, they have very poor, much lower oxygen reserves, and they tend to desaturate more easily and faster. So I think it will be important to, when you are doing all this obese cases, I think it's the same thing with general anesthesia. You just have to discuss with them the potential situations and scenarios that can happen intraoperatively, and then sort of have already a plan. For example, if just take for example, usually I do it under jet ventilation. Yep. So, and jet ventilation, the problem is, the good thing is that it's an open system, so I don't have to keep it closed. So my instruments can, be inserted and withdrawn fairly easily, right, without much problems. But the problem is when, they desaturate, then, the jet ventilation will not be able to bring up the sats. And most of the time, what I'll do is that, discuss with the anesthetist and say, okay, we're just going to go back to the closed conventional ventilation system. We just know what to do. We exchange a port, and then we close up all the holes, and then I'll seal and smother the patient, pinching the nose, covering the mouth, so the complete seal kind of thing. And then we'll just back the patient up. So I think in obese patients, this would definitely be a more frequent occurrence than, if it's just a normal, normal size patient. So you have to work, closely with the anesthetist. That's all.
I think I'm going to ask a question. So I mean, practices doing interventional pulmonology is actually varies between center to centers. In some centers, they actually they perform EBA-CBNA under rigid bronchoscopy. Some centers, like in the UK, they don't do rigid bronchoscopy at all. So what do you think is the best practice, Malvin?
So the best practice is, with most things, it's always something moderate, somewhere in the middle.
Mm-hmm.
So I think having rigid bronchoscope to perform, that's why I said healthcare utilization and expenditure, right? I mean, yeah, I'm sure a lot of people in this region do EBUS TBNA, just under conscious sedation. We don't ever, even in SGH, we don't ever put them under general anesthesia. Although I know, like in centers like Europe, they are very trigger happy to put a patient under GA, rigid bronch and stuff. But like I said, if it's not needed, you shouldn't use it unless it's like, there are compelling reasons because safety or technical issues, right? Then you shouldn't. And that's why, like I said, I always tell the hospital, sometimes the hospital admin will be looking at, oh, how many procedures that you do, right? So I said, yeah, if I want to just subject every single patient to rigid bronch and then just to do every single thing, whether it's navigation or like sampling nodules, yeah, I mean, it can be done, but it's like, I don't think it's fair, right, to the patient because GA risk, increased costs and all. But having no bailout for when you're practicing flexible bronchoscopy without a rigid bailout, I think that is potentially unsafe, especially if, for example, in SGH, we have the National Cancer Center, so there are like so many like cancer patients, all different kinds, and some very rare ones as well. And increasingly they are living much longer lifespans, right? I mean, in the past, if you have like lung cancer, you're not expected to survive, and now they just like keep on having newer and newer therapies, and therefore, the goalpost is like shifted further out, and you have to attend to all these patients and not palliate, you sort of like go in and intervene and buy them time until they get the systemic therapy and it works. So so to answer your question very in a very succinct way, I think only you should have rigid bronch especially in a tertiary center that handles all this kind of complex patients, and you should not subject your patients unnecessarily to rigid bronchoscope just because you just want to intubate, or I don't know, whatever other reason, because most of the time, all these procedures can be done under conscious sedation. Yeah. Thank you, Eric. Yeah.
Thank you very much, Dr. Malvin. So I have one question for Dr. Gurmit from Wahyu. So the question is, EBUS-TBNA is a minimally invasive technique for diagnostic and mediastinal lymphadenopathy. Although most studies have reported the utility of EBUS-TBNA in malignancy, its use has been extended to benign conditions, including sarcoidosis and probably tuberculosis. You already explained it on your lecture. should we be routinely employed the procedure? I mean, the EBUS-TBNA. Dr. Gumit, your answer.
Yeah, thank you, Dr. Eric. I think this is a nice question. Yeah, should we perform this EBUS-TBNA routinely? Yeah? So I think yes. Yeah, if we got like a patient with mediastinal lymphadenopathy, yeah, it will be much better if in our in an institution they got this modality to perform this TBNA, yeah, EBUS-TBNA. It will be much better to evaluate this mediastinal lesion. Not only mediastinal lesion, like in my presentation also I've stated some of my personal experience, like consolidation, yeah, pulmonary nodules, yeah, in a malignancy patient or suspected malignancy case, yeah, in a leukemic patient also. We find out that it comes out to be sometimes tuberculosis, and sometimes it comes out to be aspergillosis. And we have not seen any sarcoidosis cases in our institution, even though I think you are aware also, Dr. Eric, there's one patient we perform twice this EBUS-TBNA suspected cases of sarcoidosis, but again it came out to be negative. I think not only we as the man behind the gun doing this procedure, we also need our pathologists to what do you say, to have a good evaluation of the specimen that we send. Yeah, sometimes we suspect it, we are sure that we got the specimen, and through evaluation from the pathologist it came out to be negative. So coming back to the question, yeah, if we got a mediastinal lymphadenopathy, it will be much better, yeah, to evaluate. We cannot be 100% sure that it is connected to the malignancy cases. Probably might be some benign lymphadenopathy, or probably some infectious causes. Thank you, Dr. Eric.
I would like to actually ask two questions. I think I'm hoping to get an answer from both speakers, both experts. So I think the considerations about EBUS-TBNA, the first one, whether the size is matter. That's the question for EBUS-TBNA, whether the size is matter. We know there is a new needles which is slightly larger, the 19 gauge needle. Second, I'm actually I agree with Dr. Grimmet. I think it also depends with the man behind the gun. Studies, the latest study about EBUS-TBNA, it doesn't show any significant difference between the conventional TBNA size needle with the 19 gauge needle. And then that also highlights what Dr. Gurmet just mentioned. But again, back to Dr. Melvin and Dr. Gurmet as an expert on interventional pulmonology, and I believe who perform more than hundreds of EBUS-TBNA procedures. How we can actually increase our diagnostic yields. Sometimes the slow pull technique, sometimes we need to do negative pressure. Most of the time we do the slow pull method, and it also depends on our pathologist. So the big questions will be how we can improve the diagnostic yield. Yeah, I think that's the question for both of you.
So I'll take the question first. So I think it's a very good question, but that is the problem with all interventional studies, right? I mean, the issue is we cannot always, how do I say, control for the procedurist, right? The man behind the gun. So so even if you look at the latest meta-analysis on, like, whether it's radio EBUS or not, or like navigation, bronchoscopy, they are coming up with all this data that what are the factors for success. And then initially last time we used to say, oh, yeah, the radio EBUS, CT bronchosine, larger the nodule and everything. And then when they pull everything together, like I think it was not too long ago, I cannot remember which journal it was. Either it was CHEST or Journal of Interventional Pulmonology. All these factors didn't even matter. Yeah. So like I said, I don't really trust like this kind of data because like what you said, there are just way too many factors or confounders that we cannot control for. But I would say that number one, patient selection is super important still. And number two, it's not just the, like I said, the technique, right? You know, if you're going to read, everybody will just teach you, okay, this is how you do step 1 to step 10, right? But there are like so many nuances that unfortunately, a lot of textbooks don't really sort of highlight. So I'm not sure, but I've been approached by an Italian publishing house to be editor for this a new interventional pulmonology book, and my idea was that, you know, for every single procedure, yeah, I'll quote the evidence, right? But there must be some clinical pearls in procedurally to sort of like, you know, tell people, you know, if you encounter this situation, what are the possibilities and what you should do. And I think those things are not commonly taught, and because it's not, there is no curriculum, right? There, I mean, if you go even go to Professor Andre Kolb's Bronchoscopy International, and you know, I've done the EBUS, TVNA, all the assessments and everything. It it is still very just you know, the stepwise, step 1, step 2, you draw the needle, you know, blah blah blah. But you know, there are a lot of nuances that are still not being emphasized. So if you were to ask me, I think, you know, probably you know, in hopefully in a region we can, as you know, we already have a few like for example a PIPA that is trying to sort of like come up with a curriculum and teach all these things more in a more structured way for practitioners in the region. And like Dr. Gurmit emphasized, in SGH, very fortunately, we have a very, very good pathologist, like lung pathologist who trained in the United States. So yeah, she's of great help, because we all know when she's on leave, right, suddenly all our biopsies done by the usual people like come back like inconclusive. So, but you know, for her, she'll always say, oh, you know, I'll do this marker, that marker, and then, you know, how she triage her tissues. And you know, if she's not sure, sometimes she'll send them to like Mayo or stuff, or like to her colleagues in the US to discuss. So I really think, you know, there is just no straightforward answer. I think that's why it's a team, right? We work as a team. In order for us to be like very good, everybody counts. Yeah, if there's a missing a weak link, then it's not going to fly, unfortunately. Yeah.
Cheers, Melvin. Thank you very much. I think Dr. Gurmit, I think Melvin already answered the question. What we actually experience in Indonesia. Dr. Gurmit, you want to highlight something in regards to the question?
Yeah, thank you, Dr. Eric. I think I agree with Dr. Melvin, yeah, that nothing is 100%, yeah, positive. So like sometimes we see through the CT scan, we also held some meetings in our interventional pulmonology meeting or chest meeting. Radiology says that there is an open bronchus sign. We see there is a big mass in the CT scan, and when we perform the bronchoscopy and no internal mass or lesion visualized intrabronchial, and when we perform the EBUS TBLB or we perform the EBUS TBNA, and the result comes out to be inconclusive, yeah, or negative result. So I think through my personal experience, much better to discuss with the patient and the family the options that we are going to offer to the patient and the to the patient. Yeah. So step 1, if it's a peripheral lesion and it's near the pleura, we can perform a biopsy through transbronchial biopsy or aspiration. And if it doesn't, we cannot perform that procedure, we can perform through bronchoscopy, and we inform also that nothing is 100% sure. And if we get the positive results, yeah, we will treat you based on the results. And if it's negative, we have to discuss with our thoracic surgeon to perform an open biopsy. I think that is the best option, Dr. Eric. Thank you.
Thank you very much. So, I don't think I should summarize both speakers' lectures for today, but I think as an interventional pulmonology, internal medicine, interventional pulmonology, we know for sure that working as a team is a very, very pivotal, especially in establishing a patient's diagnosis and also to treat the patients better. So again, much appreciation for Dr. Malvin Tai from Singapore and Dr. Gurmit Singh from Jakarta, Indonesia. And thank you very much for this wonderful session. And I'll give back to the master. Yes, thank you very much.
Thank you, Dr. Eric. Thank you, Dr. Melvin. We'll keep in
Thank you,
touch, Dr.
Dr.
Melvin.
Gurmit.
Thank you.
Thank you, Dr. Eric.
Okay.
Thank you, everyone. Yeah.
Yeah.
Thank you.